Hi all. It took a podcast meeting to bring us all together. I think we are almost 3 years. I've not met you all. So welcome. So,
Thank you.
so I think today we will discuss about the usual and common gastrointestinal problems which we see in our daily OPD. The mainly topics and the most common diseases which we as a gastroenterologist we encounter. So let's talk about the most common presentation which we see in our gastroenterology OPD. Here the patient comes to with an imaging study stating that he or she is having a fatty liver. So what exactly is this fatty liver? Is the fatty liver disease same as fatty liver? And we are seeing a lot of obesity patients and diet which they don't properly follow. So how do you in your regular OPD, how do you tackle such patients who comes to you with already they will be really scared when they see the report they're having a fatty liver. So how usually you will approach such patients in your OPD?
Yes, Dr. Alex. So, as you rightly said, this is one section of patients who walking into the OPD with a report telling they're having fatty liver. So, basically, what we need to know is that it is an imaging, it's a radiological finding telling that there is fat in the liver, that the liver looks a bit more brighter on the ultrasound scan. And depending on the clinical situation, whether the patient is obese or have any other illnesses like diabetes or BP and things like that, we have to decide whether he or needs she needs further testing. Further testing includes blood test, that is blood test of the liver, and other testing depending on the outcome of the liver blood test. But this fatty liver basically means there is some probable fat in the liver. That's the meaning of that. It might be associated with the proper illness which might need treatment, or it might be just an incidental finding which may only need a lifestyle modification. And when we ask the patient to do a liver test, that is the blood test of liver function test, we commonly encounter changes in that. But majority of these fatty liver patients, the liver blood tests are normal. But a small cross section of them, maybe around 10 to 15% of them, I see that the liver enzymes are elevated. So, Dr. Asif, what do you do when somebody with a fatty liver disease has an elevated or abnormal blood test of the liver? How do you approach them?
In Badr movie, we see a lot of patients coming with this abnormal scan and liver function. So, in non-alcoholic fatty liver disease, the most common cause. So, there will not be much alcohol consumption. So, we have to rule out a lot of other causes like any viral disease like hepatitis B, hepatitis C affecting the liver. Okay, and any drugs like steroids taking for asthma, example they are taking. So that has to be rolled out. And rarely some diseases like autoimmune diseases.
Autoimmune hepatitis.
Rarely. These are rare. But anyway, viral hepatitis and these drugs, the history has to be taken and a thorough investigation has to be done. And nothing else is found, then we take it as a non-alcoholic fatty liver disease. And then, as you said, we will work up for uh, diabetes and hypercholesterolemia, whether high cholesterol level is present, then any thyroid illness is present, okay? And we will take their BMI, body weight, height, and we will check whether it is optimal for the age. All these factors we will check.
So, what you mean to say, Dr. Asif, it might be a spectrum of disorders.
Yeah.
Like it might be a syndromic anomaly. Many illnesses in the same patient, like probably metabolic disorders like diabetes, hypertension, with cholesterol, along with causing this fatty liver also. So, all this might be seen.
Yeah, this is a syndromic illness. So these patients with fat in the liver means they have fat in other parts of the body and they have other illness in the body like any underlying coronary artery heart disease, any kidney disease, hypertension, all possibilities are there.
All this has to be evaluated
Yeah.
and treated if seen.
So we won't look at liver alone. All these factors we will take into consideration and all these parameters we have to take care.
Mm. So not actually, not all patients need to worry when they come with an ultrasound scan saying there's a fatty liver. So we need to differentiate between fatty liver disease and fatty liver.
Yeah, the prevalence of fatty liver is now approaching almost 30 to 50% worldwide. However, in variations in different countries. So only very small percentage, 5% of people will go for advanced liver disease, cirrhosis, and even liver cancer. So that is the
Early catching
importance,
is, yeah.
early detection of this fatty liver disease. So simple fat means it will not cause much changes inside the liver. So once fatty liver disease starts, it will cause some changes and some reactions inside the liver, and that will be reflected in the liver function test and other parameters. And so there are some, of course, there are some advanced imaging techniques other than ultrasound to detect these early changes. So these type of patients we have to give more care, and they have to be under regular
Follow
follow-up.
up and frequent monitoring
Yeah,
also.
frequent monitoring. Okay.
I like I remember a case actually around 6 months back. So this patient came with to me actually. It's a South African female actually. So she came to me with saying she's having a fatty liver. She was in the mid 40s, so a little bit on the overweight. So I said them like it's a routine scan she did. She is otherwise absolutely normal, not a diabetic, no hypertension, no features of any metabolism other than the like being a little bit overweight. So I said she's having a fatty liver, but liver function test, everything's are normal, but you can just reduce your weight and maybe just calorie deficit diet. That's all what she requires. And she goes back and now we have the WhatsApp and Facebook University. They self-educate these people. So she went back. She comes after 1 month. This time her husband brings her to me. Now she comes in starvation ketosis and features of acute liver injury. She went into depression. I just said that she's having a fatty liver. But then she went back and she misdiagnosed as fatty liver disease and going for cirrhosis. So she had a complete shutdown in the calorie intake. She became very depressed. So it's very important. I feel that was an eye opener for me personally. So I had to tell her, see, what requires is only maybe a 500 or 600 calories deficit per day, or a weight reduction of around 7 to 8 pounds per month, 3 to 4 kgs. All what is required. That is enough for the liver to get normal. So that was really a eye opener. I had to sit with every patient, then explain properly. This is all what is required. No need to worry, but only taking care of and regular assess it. Need to regular follow up is what required actually.
So, Dr. Alex, what advice do you give to these patients who come into your OPD with fatty liver disease and they are found to have non-alcoholic steatohepatitis, that is fat in the liver causing damage to the liver? How do you manage them? What advice do you give?
So actually, if I categorize, I usually like we are seeing pediatric cases also now with fatty liver. In the US, I think it's around 22% of the pediatric children are having fatty liver. 50% of the obese children are having fatty liver. So it's like very prevalent now. Even if you go to a supermarket, you go to the bill paying section, you have all this colorful, wonderful chocolates. Even I get tempted to buy one. So even if you go to a shopping mall, you buy a pizza or pasta, you get a Pepsi or Mirinda along with it. So we are knowingly or unknowingly pulled into a diet which we have to follow. So I usually tell them first and foremost, if they're having an non-alcoholic fatty liver disease, diet restriction and exercise are the vital things. So exercise doesn't mean that you need to do a very strenuous exercises. Minimal exercises, 3 to 4 days a week, maybe 150 minutes a week. That is all what is required for to have an active lifestyle. And definite calorie deficit around 500 calories per week is almost that required. Not most all patients require as medications. Most only I think vitamin E and pioglitazone has been found effective in such patients. So regular follow-up and weight reduction and diet is paramount in such patients, I feel.
I think, like Dr. Alex said, basically a caloric deficit diet and management of other, if at all, any other complications, other illnesses like hypercholesterolemia or hypertension, diabetes, all that, along with weight reduction and a healthy lifestyle with a deficit reduction in calorie intake. I think that would be the ideal treatment for people, such people with fatty liver disease.
The real life scenario is that if we advise this diet modification, exercise, weight reduction, people are not satisfied with it.
Yeah, true.
Drugs have very minimal role in this management of NAFLD. Still, a lot of drugs are there in the pipeline, but still the first, second, third line of treatment lies in this diet modification and this lifestyle intervention. Okay, and definitely, as you said, you have to reduce the calories and walk at least 20 to 30 minutes. That is brisk walking, 100 steps per minute. Okay, for in 5 days or 7 days per week. And then even if 10% weight reduction, that will definitely resolve the disease, okay, in the early stages. And even if the weight is not lost, that will definitely reflect in the liver. Weight loss, even if weight loss doesn't occur, you have to continue the diet modification and exercise. That is very important. But most of the people, they don't
want
understand the importance of this.
Right.
Dr. Abhi, you advise coffee for this patient?
Yes, coffee, as you said, Dr. Asif, is a viable treatment option for these people. Like 2 or more cups of black coffee without sugar. I mean, you don't want to add sugar and increase the calories. So, coffee is a treatment, is a recommended kind of treatment for non-alcoholic fatty liver disease. That can also be tried along with lifestyle modifications and all, provided the patient doesn't have any significant gases or acidity problems. That we definitely
You
do that.
also routinely advise
Coffee, no. To be honest, not really, because most of the patient comes to it with the GERD also. But yes, as I said, if they are drinking coffee, I don't stop them. I said, okay, 3-4 glasses of coffee is okay. So especially there is no harm in. I always suggest, okay, in such cases, coffee is better than tea for the liver. Definitely, it's better than tea. So now, if you see, which let's discuss about which another one topic which we usually don't want to discuss and we usually don't want to disclose, colonic cancer. So we are seeing a lot of colonic cancer now. I think it's most because we are doing extensive investigation. I think before 40-50 years, there's nothing called colonoscopy or CT scan. Contraceptive was not there. I think thanks to the imaging studies which we do now, we are seeing a lot of colonic cancer. Though we are shattered to say that he is having a colon cancer, somewhere in our mind we think that, oh, it's colonic cancer, it can be completely cured, provided it's been early detected and it is in a safe area. It's like less invasive, and it don't spread like other invasive cancer like in the upper GI tract, like esophageal, pancreas, or stomach cancer. So somewhere we feel like, okay, colon cancer, you are safe, but it becomes very tough to explain to the bystanders also. How often, sir, do you see such colonic cancer who present lately, which could have been dealt differently if it have presented early? I think it's very common in Oman also.
here in Ruby, we are getting a lot of colon cancers. And now, in the recent 4 months, I have got 3 patients, three females, less than 45 years, all with advanced malignancy. Yeah, last week also, I had one malignancy. So, as the international scenario, the colon cancer in the young persons is on the rise.
I see.
And internationally, it is almost the third most common cancer, I think, colon cancer. So, and the importance of colon cancer is that if you detect it early, in the early stage, that pre-cancerous stage, means polyps, like pimple-like things occur inside the colon, which can be easily detected by colonoscopy, that is checking with the camera. And if you remove it, it is 100% prevented. Then you do periodic checkups. And we can detect, because once this develops, these people have a tendency to develop in the future also. So you do periodic checkup and remove it. Then you will be on the safe zone. So here also we detected three cases in the last 4 months, 45 years.
Yes, even in Al-Quds, as a whole in Oman, the incidence of colon cancer is not rare. It's quite common actually. Colorectal cancer, I think, is the second most malignancy in Oman. So even last week, there was a lady around 35 years old, quite young, 35 years old, around 2 months history of some changes in her bowel habits, some loose motion, some constipation, mild hemoglobin less. And since the symptoms were not going away, I thought we will do a colonoscopy and see. And even her stool test was showing a bit of blood, but she never noticed the blood, even though the stool test showed blood. So I thought very well we'll go ahead and do a colonoscopy. And at the time of colonoscopy, she had a full-blown malignancy in the rectosigmoid area, in the lower part of the colon. And I just referred her for surgery. So what I see, I've been here for the last 5 years. What I see is the incidence of malignancy, colon cancer, is quite common in Oman. And recently, what I'm seeing is the incidence is getting more common in the younger age group. That is that sub 40 age group also we are seeing more cases now. Even though the median age of colon cancer is well above 60. Yeah, so we see more of patients in the sub 40 age group. And that I think needs to be seen, and some kind of study needs to be done probably to see why it's getting more common. So, Dr. Asif, what do you suggest? And in this scenario, when we see lots of colon cancers in Oman, and this age is coming down drastically, what do you suggest to this general population as well as to people who already are diagnosed with colon cancer, to their family and their relatives? Do they need to be more extra careful?
Yeah, okay. As I said earlier, colon cancer can be detected in the precancerous stage. Okay, and if it is removed, it will definitely prevent the development of cancer, polyp removal. So there are certain indications for checking these people without any symptoms. As you said, if there is a family history of colon cancer, definitely father, mother, or siblings, anyone has this, definitely at the earliest it is better to go for the colonoscopy. Screening. Yeah, screening. That is screening without any symptoms. And internationally, if a patient with more than 50 years, we can take him for screening colonoscopy, and because there is a high chance of detection of polyps. Now they are trying to reduce the age to 45 years because due to this rise in colorectal malignancy in young individuals. So my opinion is, always, if family history is there, you should do a colonoscopy. We will advise patients to inform the near relatives also. And age above 50 years, either if they come with any gastrointestinal problem, it is better to do one colonoscopy.
Even in a general population without any symptom, we have to advocate the colonoscopy, that is screening colonoscopy, every 5 to 10 years in a general population.
Yes, yes.
This is actually true in Western countries where to renew their insurance, it's mandatory that post 50 they should do a screening. So it's not so prevalent here.
They will get a call from the hospital that there is due for colonoscopy, and
So
they can do it.
it's high time that we also implement such things.
It has not picked up in Oman. I think since the prevalence of colon cancer is quite high here, I think that has to be implemented here also.
What are the symptoms body show in a person with colonoscopy?
For
colon cancer.
So usually any patient we call the red flag signs. So any patient who has, like as you said, sir, more than 40 or 50, who has sudden change in bowel habits, even one episode of bleeding per. I still remember my professor saying to, if you see one patient with one episode of bleeding per and you have ruled out his so-called infection, hemorrhoids or fissures, he or she should undergo an index colonoscopy procedure to find out is there any polyps or any pre-malignant condition or malignancy. So weight loss, sudden change in bowel habits, bleeding per rectum, low hemoglobin, stool occult blood saying positive. Definitely, I think it's mandatory that without late, rather than it getting delayed and in advanced stage, he should undergo a colonoscopy.
Last year, one patient, he came here after hemorrhoid surgery, from not from Oman, that's it. Then he was detected to have colon cancer. Then he had to undergo colectomy.
That's what I also see many people walking into OPD telling they have some blood in the stool, but they tell it is probably because of hemorrhoid. So I'll take some medicine now and we'll see. So that is never a good idea. So whenever somebody is having a blood in the stool, it always has to be tested and the colonoscopy has to be done and made sure that it is not a colon bleeding polyp or maybe a ulcerative colitis or a colon cancer, particularly in people who are above 40 years of age. So
When I had a patient actually, this was the initial days, like 3 years back. He was an expert, an Indian from Hyderabad, I mean 42 years of age. So he came with history of 4 years of bleeding per rectum, diarrhea, weight loss. He had underwent hemorrhoidectomy once and he's been chronically on antibiotics and anti-hemorrhoidal medications. But he presented with a different complaint to me. He presented with jaundice. So when he examined, he was having a hepatomegaly. Then we did an ultrasound. It came to be a cholangiocarcinoma. Then we did a colonoscope. It came to be an ulcerative colitis untreated. Still, he's in contact. He's there in Hyderabad. He escaped. But this he would have done 4 years back, 5 years back. Could have avoided such catastrophes.
Doctor, whether dietary modification, lifestyle changes are helpful in this tackling this colorectal malignancy.
So, what studies have shown is high fat content with high red meat and too much oily stuff and all. They definitely, it's a risk factor for colon and breast and other few malignancies. So, what a healthy lifestyle would be to cut down on red meat, processed food and all, and probably increase the amount of fiber in the diet. Fiber-rich foods, as you know, is fruits and fresh fruits, green leafy vegetables that would help to combat this inflammation happening inside the colon. So cut down on red meat and increase on fruits and fresh vegetables. So that would be the dietary advice for this.
So, any role of addictions in this development of malignancy?
Addiction, see, smoking, and we say if you don't get any reason for anything, we say smoking is a risk factor. So most commonly in the upper GI, but yes, definitely smoking is a risk factor for developing colon cancer. But it's not a proven that smoking is it's a cause, but it's an added risk factor. As said, actually, red meat is an added risk factor. So like smoking is also an added risk factor for getting it. So as you both suggested, I think screening is the most important part of colon cancer. But screening is also important in the upper GI symptoms also. So when someone comes to you with upper GI symptoms, which is refractory to medications, it becomes mandatory that we do a scanning for you do a screening endoscopy. It's a endoscopy also, so we can upper GI endoscopy, so we can rule out other diseases other than. So most of them they'll be taking pantoprazole, omeprazole for a long time, and they will not have some symptom relief saying it's only a gas. So more than screening endoscopy also becomes equally important. How do you tabulate or how do you select a patient who needs an endoscopy in your routine practice?
Uh, as you said, especially age is above 50 years. Even the first presentation, we can take the patient for a endoscopy. Recent change in habits, bloating, abdominal pain, weight loss. Okay, after doing the routine investigation, guideline says that we can take him for a endoscopy of the stomach. Okay, but if there are some alarming signs like persistent vomiting, significant weight loss, or any difficulty in swallowing, or low hemoglobin levels, then the endoscopy is definitely indicated, especially in a young individual. So then those patients whose symptoms are not improved after giving medicines for 1 or 2 months, definitely you have to go for this endoscopy.
That's what I've seen in many people come to us after 4 or 5 months of taking medicine for gases and acidity. So all doctors treat acidity and gases, be it GP doctors or internal medicine, internist doctors and all. What I personally do is I never give medications for more than 2 months without a diagnosis. So whenever somebody has a new onset symptom, even though it looks innocuous, if it is lasting for more than 2 months, I always do an upper GI endoscopy. Make sure there is nothing else like ulcer disease or a carcinoma of the stomach or things like that. So anything 2 months is the cutoff which I have kept. Anything more than that, I always evaluate. And without a diagnosis, there is no point in taking medicines for a long time.
Yeah, 2 months back, 3 months back, one patient from India came to my OPD with abdominal pain and did CT scan. There was extensively spread cancer. So I took his history. He visited me two years back with this gastric symptoms, but that time I had advised endoscopy, but he was not willing.
Also
Now he presented with
advanced.
advanced. But if you do 100 endoscopies, only one or two ulcers or cancer will get. Otherwise, if you don't do, this one or two will miss.
It is again a life-saving procedure, probably. If you diagnose it early, you can treat it early and save that patient. So that chance
Now
is
he presented with
yes, no, malignancy is
Similarly, I think 6 months back, it was actually referred to me from a polyclinic nearby Falaj Polyclinic. So this it's a female, 60-year-old female. She presented with chronic pain abdomen. So ultrasound was showing like colon, like intestines was inflamed. So then I did like she was already on antibiotics. All her inflammatory markers were elevated. Like I thought, okay, we will just do an index without preparation. I just did. I'm only up to the rectosecum. That was the area where it was inflamed. When I did a sigmoidoscopy, what I found was that there was a fish bone which has pierced into the rectosigma, the distal part of the colon. That was causing an inflammation. She was suffering from this for more than 3-4 months. It was whole area was inflamed, and I had to call the surgeon nearby before because I don't know whether it can pierce back and become more. So luckily we removed it and she's doing well. So how important is a endoscopic procedure in such scenarios? You need to know that. But after doing all this endoscopy, colonoscopy, CT scan, imaging, you still get subset of patients where you don't find a reason. So then comes the diagnosis of functional bowel disease. So now it's a trend that we are hearing brain gut axis, gut brain axis. What exactly is it, sir? Is it really problematic? Do you really need to, what you call that, give stress on that? I feel like our intestines are like more or like a very busy street. You have someone going here, coming here. The right signals are not there. You don't reach anywhere at the right time. So what is it actually? Could you explain in simple terms what that benefit?
Dr. Alex, you're talking in terms of irritable bowel syndrome, right? So basically, this is a syndromic syndrome where you have abdominal pain, some vague pain in the abdomen with changes in alteration in bowel habits. Some people get constipation, some people get loose stools, and along with that, there is some change in the form of the stool. Sometimes it is like stone like, sometimes it is like a bit more harder than normal, sometimes it is watery and so on. So this condition is called irritable bowel syndrome. So basically pain along with change in the bowel habits. It is very common. Anywhere in the world it's quite common, and particularly I would say around 20-25% of any patient coming to the OPD, any gastro OPD is IBS. IBS is irritable bowel syndrome. So basically, what IBS is, it's a problem of the brain gut axis, as you rightly said. Brain gut axis is a two-way street. That's what I would say. That is the mind and the gut, the abdomen, the intestines are closely related, the colon. Any changes in your mental state like stress or anxiety and things like that can affect your colon and the gut. So that might cause a bit of discomfort and pain and maybe changes in bowel habits. That is quite common. The other way is, as I previously told, it's a two-way street. Changes in your bowel can also affect your mood. So it's two ways. So that is this brain gut axis. It's not a very complicated thing again, but it's a functional disease. So it discomforts people. They get pain and discomfort. But you do all evaluation, you do a stool test, you do a CT scan, you do a colonoscopy, but you don't see anything. So basically, it is a diagnosis of exclusion. So you do everything, nothing is there, and it is fitting into the criteria. Probably it is a irritable bowel syndrome, which is a functional bowel disease. That is, it is not a very serious problem, even though it causes symptoms.
Convincing patients is easy, but convincing parents it becomes all the more difficult. Children, we have to convince the parents, yeah, your child is okay, but she or she is suffering from an IBS. How do you like pediatric patients? You are seeing more common like this IBS kinds of
IBS in pediatric patients.
like more than 15, 14 years like that.
Yeah, now due to this busy life and stress in academics, a lot of people, youngsters and around 15 years, people are coming with these type of symptoms. And mainly we will take a detailed history.
Okay.
And as he said clearly, it's a functional disease. There will not be any other major issues like any blood in stools or any severe weight loss, fever.
Okay, sir.
So if these are there, definitely we have to be careful and we have to think of any other diagnosis.
Okay, sir.
So this is less likely to be irritable bowel syndrome.
Okay.
So first we will do investigations, as he said, blood investigations. If requires stool test, colonoscopy, imaging, and if all are normal, then we label it as IBS.
Okay.
And we will discuss with the patient and his caretakers. And there is no significant disease inside. It is a abnormality of the function. Sometimes some contractions and relaxations of the intestine, stomach occurs, and that can cause this.
Okay.
And for this, we will advise some lifestyle and diet modifications,
Okay.
and we will give some medicines and more, and we will follow. And it will take at least 3 to 6 months to get a good result.
How, Dr. Alex, how do you manage these patients? One is you have to convince the patients that it is not a severe illness, it is a functional disease. And if at all you need to go for proper treatment, what are options do you have? Do you have a lifestyle modification like we discussed in other scenarios, or you go directly for medical management? What do you do with these patients?
Usually in such patient, as you said, sir, convincing the patient becomes paramount. Here, they will not be ready to accept that you are having a normal. It's actually a function of the colon is not normal, but structurally it's absolutely normal. But most of them will not accept it. So once I rule out kind of other what you call it irritate like gluten allergy or lactose allergy, so then there's something called as which is coming a FODMAP. So I'll ask them, say these are the subset of food which you need to avoid, and say best example is to keep a food diary. Ask them to write down all the food which he's taken the last 1 month and see properly which food is there. If it is comes on the food map, just avoid this. And some basic investigations in the point, if the patient is constipated or diarrhea, do a basic test like doing a calcium and doing a thyroid stool routine, and then diet. That's it. And some sort of simple medications which will be really helpful. What is what required, provided there is no warning signs.
But this is a low FODMAP diet, Dr. B.
Yeah, FODMAP is something which has come up in the last few years, around 8 to 10 years, this new concept. FODMAP is fermentable oligosaccharide, disaccharide, and monosaccharide. In simple terms, it is some food which can cause increased gases and bloating. It includes vegetables and fruits and some other things. Common things I would say is dairy products, okay? Then garlic, onion, mushroom in vegetables, apples, legumes, pulses. These are the common things which increases the bloating and gases. Wheat, barley, oats, all these are actually high FODMAP. These high FODMAP diet can increase bloating and gases and cause more discomfort in people with IBS. So if you try to cut down on these, that might help with the gases. It is not 100%, but it can help. So we can very well try asking patients to, like you said, to maintain a food diary and see if they are taking any of these. If at all it is there, then cut down on those. And this many items used in artificial sweeteners and all, no? Even that can increase the bloating and gases. So cut down on that. That might help, but that is definitely something which we can try.
It's very tough to convince and treat cases. They will be having this window shopping, like doctor shopping. We'll go to each doctors, find out. Then it's kind of convincing that we can go. How do you feel, sir? Smoking, does it have any effect on colon?
Smoking, I would say, definitely is not a good habit to have. There is nothing positive to come out of smoking. So, any of these illnesses, be it colonic cancer or a stomach cancer, upper GI cancers, esophageal cancer, IBS, and all these kind of illnesses may or might have a link with smoking. So, always advisable is to stop smoking. There are no two ways about it. Smoking is a bad habit, it has to be stopped. Yeah, so Dr. Asif, Dr. Alex, we met after a long time. We've been talking over the phone and all, but personally, we met after a long time. And I think we had a very fruitful discussion. We covered lots of topics, including liver, colon, and regarding gut-brain axis and smoking and many other things. So it's been very fruitful, enriching. I think it will help the patients also a lot. Thank you, Dr. Alex. Thank you, Dr. Asif, for the wonderful insights. Till we meet again. Thank you.